Welcome to the audio digest of the American Journal of Psychiatry. This is Michael Roy with highlights from our October 2010 issue. This month, we've got several topics of interest to clinicians. Our Treatment in Psychiatry feature discusses delirium in infants in critical care settings. Highlighted research includes a study of suicidal women with borderline personality disorder that compared subgroups with and without post-traumatic stress disorder. An editorial discussing this study examines implications for diagnosis and treatment. We'll also discuss the diagnosis of mood disorders, specifically hypomania that falls short of the criteria for bipolar disorder, since in the National Comorbidity Survey replication, respondents with major depressive disorder were asked about hypomanic symptoms, and these turned out to be fairly common. Another study we'll review examined how step therapy for antidepressants relates to overall medical utilization and spending. And we'll cover a study that showed how hypertension and body mass index affect cognition in schizophrenia. This article has been selected as meriting CME for those readers who subscribe to the AJP CME course program. Each month, brief companion exams are created for 3 of the most influential articles from the issue. By reading the articles and completing the online exam, individuals can earn up to 1 AMA PRA Category 1 credit per article. This activity is sponsored by the American Psychiatric Association. To subscribe, click on the CME link at our homepage, ajp.psychiatryonline.org. The October issue also contains several other great features, including a review article by Carol Taminga and colleagues on the hippocampal formation in schizophrenia. The APA presidential addresses from the May 2010 annual meeting are featured, and some of the DSM-5 architects provide a commentary on the upcoming field trials. But now, let's get back to the audio highlights. First, Gabrielle Silver and colleagues present our Treatment in Psychiatry review of Infant Delirium in Pediatric Critical Care Settings. The article begins with the hypothetical case of an 8-month-old infant with stage 4 neuroblastoma. She became very agitated, pulled out her intravenous lines, and appeared not to recognize her mother. An EEG showed no seizure activity, but an MRI showed extensive metastatic disease. A diagnosis was made of multifactorial delirium due to underlying disease, hypoxia, toxic medication effects, pain, sensory deprivation, and trauma. A trial of intravenous haloperidol was recommended, with a dose based on guidelines for children older than 3. The goals were to immediately achieve safe airway management, lower distress, and allow reduction of potential offending agents such as lorazepam, pentobarbital, and opioids, which had been given for sedation. The infant's agitation and delirium improved, but she developed repetitive movements, and so the haloperidol was cross-tapered over 3 days to quetiapine. Pediatric dosing guidelines for quetiapine exist only for children over age 13, so the patient was given a dose equivalent to about 1/4 of the starting dose for a 40-kilogram child. She was then able to tolerate her chemotherapy and oral feedings, and was more consolable and interactive. Later, the quetiapine was discontinued with no adverse events. Prior research is limited, and clinicians should be aware that for this age group, untreated delirium may affect development. The DSM-4 criteria for delirium are acute onset of disturbances in arousal and cognition in the presence of an underlying general medical condition. Children have been found to have similar pattern of symptoms. 3 clinical subtypes have been recognized in both adult and pediatric patients: hyperactive, hypoactive, and mixed. Hypoactive delirium is underrecognized because it's not as disruptive. Children and elderly patients are more vulnerable to delirium. Delirium can originate in any number of pathways associated with illness or an intervention: oxygen deprivation, inflammatory cytokine release, modification of the blood-brain barrier, sickly thyroid syndrome, upregulation of the hypothalamic pituitary adrenal axis, and disruption of the intracellular second messenger systems. Dysregulation of multiple neurotransmitter systems probably contributes to the symptoms. Acetylcholine and dopamine in particular have been implicated. From research in traumatic brain injury, epilepsy, and meningitis, it's clear that the immature brain has different responses to oxygen deprivation and cytokine release compared to the adult brain. Long-term studies of neurocognitive outcome in child survivors of untreated delirium are needed. Also lacking are screening instruments for the very young. The Pediatric Confusion Assessment Method for the ICU is the first validated screening instrument for critically ill children that can be used by staff to rapidly assess ventilated and non-ventilated patients over age 5. It contains yes-no questions, pictures, and hand signals, and evaluates the child's inattention and disorganized thinking. The Pediatric Anesthesia Emergence Delirium Scale was developed for emergence delirium, which occurs when children are awakening from anesthesia. The instrument includes items about the child's eye contact with caregivers, awareness of surroundings, purposeful nature of movements, ability to be consoled, and restlessness. It's been validated in children from 19 months to 6 years of age in postoperative settings, and is being studied for use in pediatric ICU settings. Antipsychotics are rarely used for treatment, but a growing body of research supports the efficacy and short-term safety of both conventional and atypical antipsychotics. When considering treatment for delirium, it's imperative to consider the underlying illness and treatments, offending agents such as medications, and environmental factors. Steroids, benzodiazepines, opioids, propofol, and ketamine have potentially neurotoxic effects. Recent biochemical research has shown that the toxic effects are mediated through complex pathways that may have pro-apoptotic mechanisms, as well as through the enhancement of GABA. Research indicates that antipsychotics may be neuroprotective. Atypical antipsychotics enhance cellular uptake and metabolism of glucose, and they may make cells more resistant to cellular stress and restore levels of nerve growth factor and brain-derived neurotrophic factor. A developing literature indicates that typical and atypical neuroleptics can safely and quickly resolve delirium in even very young children. As in adults, the choice of antipsychotic may be based on a model of high dopamine for hyperactive delirium and low dopamine with cholinergic imbalance for hypoactive and mixed delirium. Haloperidol may be more effective for hyperactive delirium because of its narrower targeting of the dopamine D2 receptor. Atypical antipsychotics have wider receptor effects, and so they may be more useful in mixed or hypoactive delirium, and they may also produce fewer cognitive side effects than conventional antipsychotics. All antipsychotics carry the risk of QT prolongation. Children with medical illness may have electrolyte abnormalities, infection, hypoxia, or exposure to other cardiotoxic drugs. All of these can increase the likelihood of cardiac arrhythmias with antipsychotic treatment. While most children in pediatric ICUs are already receiving continuous cardiac monitoring, it's prudent to also monitor QTc, electrolyte levels, and drug interactions during treatment with antipsychotics. If cardiac risk is low and antipsychotics are used, multiple factors may bear on the specific drug choice. Intravenous haloperidol has many benefits in cases of reduced gastrointestinal absorption or acute psychomotor agitation because it can be rapidly administered and absorbed. It also has minimal effects on blood pressure, respiration, and heart rate, has a low sedative effect, and has few anticholinergic side effects. In less acute situations, and when oral medication is possible, atypical antipsychotics are preferred. The choice of atypical agent can be based on side effect profile. As mentioned earlier, trauma can be a factor in delirium in the pediatric ICU. It can also be important in borderline personality disorder. Our first research article is a study by Melanie Harnett and colleagues of impact of co-occurring post-traumatic stress disorder on suicidal women with borderline personality disorder. PTSD is common in borderline personality disorder, but not much is known about its impact on clinical presentation, functioning, and behavioral patterns, especially in patients who are suicidal. The authors recruited 94 women with borderline personality disorder from a randomized study of outpatient psychotherapy. Each of them had intentionally hurt herself at least twice in the past 5 years. At least one of these acts occurred in the 8 weeks before the study, and at least one was a suicide attempt in the past year. More than 50 of the women met diagnostic criteria for current PTSD, and this group was compared with the borderline women who were considered suicidal but didn't have PTSD. Traumatic events were assessed with 2 self-report instruments, the Traumatic Life Events Questionnaire and the Childhood Experiences Questionnaire. The borderline patients with PTSD reported more traumatic events and more unwanted sexual events. Several characteristics of the suicide attempts and self-injuries were recorded. The suicide attempt self-injury interview was used to evaluate the frequency, intent, and severity of intentional self-injury in the previous year. In addition, subscales allowed ratings of lethality, suicidal intent, likelihood of rescue, use of intentional self-injury to get something from others, and emotional relief. Additional items determined whether intentional self-injury was triggered by reminders of trauma, such as flashbacks or nightmares. The patients with PTSD reported less suicidal intent, lower lethality, and greater use of intentional self-injury to influence others. Also, more of their intentional self-injuries were triggered by flashbacks, nightmares, thoughts about sexual abuse or rape, or talking to someone about sexual abuse or rape. There was also a trend indicating that patients with PTSD had engaged in more non-suicidal self-injury in the past year, but this difference fell short of statistical significance. Another analysis included the same variables but considered only suicide attempts, excluding non-suicidal self-injury. The women with PTSD were more likely to attempt suicide for interpersonal influence, and their suicide attempts were more likely to be preceded by flashbacks or nightmares, or by thoughts about sexual abuse or rape. Notably, the patients with and without PTSD did not differ in terms of the frequency, intent, or lethality of suicide attempts. There also wasn't any difference in the rates of other Axis II disorders, but the patients with PTSD had higher rates of several Axis I diagnoses: panic disorder, agoraphobia without panic disorder, and obsessive-compulsive disorder. Emotion regulation and expressivity were also evaluated. The women completed 3 self-report measures: the Difficulties in Emotion Regulation Scale, the Berkeley Expressivity Questionnaire, and the State Trait Anger Expression Inventory. The scores indicated that the patients with PTSD had greater emotional dysregulation, greater anger suppression, and less expression of positive emotions. These findings have clinical implications. For the suicidal women with both borderline personality disorder and PTSD, self-injury was more likely to be triggered by trauma-related events. These women may have more potential triggers and a heightened reactivity to trauma-related cues. So for some individuals with both disorders, it may be necessary to address the criterion behaviors of PTSD. Short-term solutions may help, such as skills to increase tolerance of distress and to manage triggers. The long-term solution will likely require the resolution of PTSD through more targeted treatments. The women with borderline personality disorder and PTSD also had difficulty expressing positive emotions. This is consistent with the PTSD diagnostic criterion of restricted range of affect. In addition, theories of PTSD emphasize the extremes in emotional responding that are characteristic of this disorder. The vacillation between overwhelming emotions and emotional numbing may exacerbate the emotional dysregulation that's a core feature of borderline personality disorder. The editorial, by Burr Eichelman, highlights several important aspects of the study by Harnett and colleagues. First, the study shows that structured research into the phenomenology of borderline personality disorder can be done, and that the research can glean productive elements for both treating psychiatrists and clinical researchers. So far, the literature on risk factors, and treatment for both parasuicidal behavior and suicidal attempts in these patients is limited. In this study, patients with borderline personality disorder and PTSD had more non-suicidal acts than patients with borderline personality disorder alone. Initial reading of the data suggests that since the proportion of serious self-injury is lower in the group with both disorders, the risk for serious self-harm is also lower. This reading is erroneous, since the percentage is generated from a higher baseline of total events. If we count the number of serious self-injury attempts, there's no difference between the borderline groups with and without PTSD. Clinicians should not be disarmed by the patient who has many non-lethal parasuicidal gestures. Their baseline risk for serious self-injury appears equivalent to the risk for the patient without non-lethal gestures. This confirms the clinical adage about the high probability of lethality, even in patients who have made many non-lethal gestures. A second finding is about the nature of the precipitant for suicide attempts. For patients with borderline personality disorder plus PTSD, the trigger is more likely to be related to interpersonal issues. This implies that interventions to prevent suicide may need to be different for patients with and without PTSD. Protection for the dually diagnosed woman may need to be shaped more like a relapse prevention model for substance abuse. In that situation, relapse prevention takes into account the personal nature of contacts with the dealer, or even the location of the drug purchase in the patient's daily life. For the suicidal patient with borderline personality disorder and PTSD, a similar investigation of personal triggers and cues may be effective. Subjects with both diagnoses were more likely to use intentional self-injury to influence other people. This offers a possible means of intervening in the dynamics of such behavior and a possible avenue to tailor more specific interpersonal interventions. Psychosocial functioning and treatment for mental health and general medical conditions didn't discriminate between the two groups. There may be a ceiling effect due to the patient's suicide attempts, with both groups having impaired function and equivalent treatment utilization. Patients with both diagnoses had nearly twice as much exposure to unwanted sexual experiences as did the group with borderline personality disorder only. But even the women with only borderline personality disorder reported an average of 25 lifetime traumatic events. It's been argued that due to the high rate of trauma in patients with borderline personality disorder, this condition is in the same diagnostic category as PTSD and varies only by intensity. The study by Harnett and colleagues offers a fairly substantial rebuttal. It indicates that there are qualitative differences in the characteristics of patients with borderline personality disorder only and those with PTSD in addition. Now we'll turn to the diagnosis of mood disorders, where Jules Angst and colleagues examined subthreshold bipolarity in subjects with major depressive disorder. More than 5,000 respondents from the general population were included in the National Comorbidity Survey replication. a representative face-to-face survey between 2001 and 2003. Diagnoses were based on the Composite International Diagnostic Interview. Mood disorders were diagnosed following DSM-4 criteria, except for the requirement that symptoms not meet the criteria for a mixed episode. 2 questions about increased activity and irritability were used to screen for mania. If respondents had either of these qualities, the entire mania module of the interview was administered, and the respondents were queried about 15 symptoms of mania. 17% of the survey respondents met DSM-4 criteria for major depressive disorder. About 40% of them also reported 3 or more manic symptoms, and they were classified as having subthreshold mania. This was nearly 7% of all the people surveyed. Important differences were observed in their clinical characteristics. Compared to individuals with major depression alone, those who also had subthreshold hypomania had an earlier onset, greater comorbidity, more episodes of depression, and a trend toward more suicide attempts. They also differed from the respondents with bipolar II disorder, but the differences were due to the greater severity of bipolar II disorder, rather than the basic expression of depressive or hypomanic syndromes. In addition, a family history of mania was as common in the group with subthreshold hypomania as in those with mania or hypomania. The high frequency of subthreshold hypomania among those with major depression confirmed the findings of a population-based study of young adults that also revealed that approximately 40% of those with major depression may manifest bipolar disorder. These findings have important clinical implications for the evaluation of mood disorders. If there is a substantial group of individuals with major depression who have hidden bipolarity, it would be critical to include careful evaluation of a history of hypomanic symptoms and a family history of mania. Next up are the effects of hypertension and body mass index on cognition in schizophrenia. Risk factors for cardiovascular disease are also important in the development of dementia and more subtle cognitive decrements. However, their impact on the cognitive function of patients with schizophrenia remains underexplored. So Joseph Friedman and colleagues compared 100 patients with schizophrenia and 53 non-psychiatric comparison subjects from an internal medicine clinic. Most of the schizophrenia patients were receiving second-generation antipsychotics. The neuropsychological test battery evaluated verbal learning and memory, the speed of visual and motor coordination, the ability to alternate between sets, verbal fluency, working memory, attentional capacity, and distractibility. The designation of hypertension was based on a review of the subject's medical history. All of the participants with hypertension were receiving antihypertensive treatment at the time of assessment, and their blood pressure was under control. Body mass index, or BMI, was calculated, and a BMI of 25 or higher was categorized as elevated. The schizophrenia patients performed worse than the comparison subjects on all of the cognitive measures. Hypertension had significant negative effects on delayed memory in both the schizophrenia and comparison groups. It also had a negative influence on recognition memory in the schizophrenia group, but not the comparison subjects. For immediate memory, within-group differences were significant for the comparison group, but not for the schizophrenia group. Hypertension had no significant effects on any of the other cognitive measures, and there were no significant interactions between a schizophrenia diagnosis and hypertension. After adjustment for the effects of age, gender, education, and ethnic group, and correction for multiple comparisons, a BMI of 25 or higher had a negative effect on delayed memory, but the effect fell short of statistical significance. When the effects of hypertension were entered into the model, the effects of elevated BMI on delayed memory were weakened. No interaction effects were observed between a schizophrenia diagnosis and high BMI on any cognitive measure. The negative effect sizes for hypertension and high BMI were larger in the comparison group. However, a diagnosis of schizophrenia in itself significantly impaired cognitive performance, and hypertension and high BMI had additional negative effects on cognitive performance in these patients. All of the subjects with a diagnosis of hypertension were being treated for it, and the effects of hypertension were restricted to verbal memory. Other studies have also shown a restricted pattern of verbal memory impairments in hypertensive patients receiving treatment. In contrast, untreated hypertensive patients show a more widespread pattern of neuropsychological impairments. These extend to executive functioning and motor speed, as well as verbal memory. The findings have important clinical implications. Patients with schizophrenia have a much higher prevalence of vascular risk factors than does the general population. Lifestyle factors contribute to this elevated rate, but certain second-generation antipsychotics also increase risk. Compounding this problem is the undertreatment of patients with schizophrenia for hypertension and excess weight. Since these conditions are common and modifiable, their treatment might significantly improve cognitive outcome in schizophrenia. Economic outcomes were the focus of Tammy Mark and colleagues. They studied the effects of antidepressant step therapy protocols on pharmaceutical and medical utilization and expenditures. Step therapy requires members of an insurance plan to first try medication within a specified group, usually a generic, before the plan will cover a second-line agent, usually a branded product. Prior research has focused on the effects of step therapy on drug use and spending. The present study focused on the use and cost of both medication and non-medication medical care. The data source for the study was the Thomson Reuters MarketScan Research Database. It represents the healthcare experience of enrollees in employer-sponsored health plans in the United States. 2 firms that had recently implemented step therapy were identified, along with 2 that did not have step therapy. The step therapy programs began in 2003 and 2004. Both of them were administered by the same pharmacy benefit manager. The present analysis focused on step therapy programs for antidepressants because these are among the most commonly used medications. More than 60,000 employees and dependents used antidepressants, and the analysis covered their treatment for more than 3 years. About 1/4 of them were in the step therapy plans. The average number of days for which patients were supplied with antidepressants was lower in the step therapy plans than in the comparison plans. However, the difference declined with time, and a year after step therapy was implemented, the number of days supplied with antidepressants in step therapy began to exceed the days supplied in the comparison plans. The number of prescriptions of all types, and their cost, were also lower in the step therapy plans, although the difference in cost fell over time. Patients in the step therapy plans used more generic antidepressants. By the second year, the proportion of days for which generic antidepressants were supplied was 24% higher for step therapy. On the other hand, antidepressant users with step therapy made more outpatient office visits. Costs were also higher, but the difference wasn't statistically significant. Both utilization and costs were higher for emergency room visits and for inpatient admissions in the step therapy plans. For the 3 months immediately after step therapy began, the number of emergency room visits was more than 1/3 higher for employees with step therapy than for the comparison subjects, and the difference grew over time. Emergency room spending for the step therapy groups was consistently higher than for the comparison group. Inpatient costs were actually slightly lower with step therapy in the first quarter after it was implemented, but in the second quarter the inverse was true, and by 2 years the average inpatient cost with step therapy was more than $50 higher per quarter than in the comparison plans. So the drug savings were offset by higher medical spending, and there was no net change in total spending. Therefore, healthcare programs that are structured to address pharmaceutical use in isolation from medical utilization may be operating at cross purposes. This wraps up our audio highlights of the October issue of the American Journal of Psychiatry. Please visit our website, ajp.psychiatryonline.org, for the complete versions of these and other articles, including author affiliations and financial disclosures. We also welcome comments about our audio digest. They can be emailed to Jane Weaver. Her email address is jweaver@psych.org. Next month, our audio program will highlight changes in the public perception of mental illness, the genetics of autism, neural activity associated with postpartum depression, and a comparison of psychotherapies for older adults with major depression. We hope you'll join us. Thank you.